Okay, I should start recording. So this is an intimate group. So the idea will be sharing our experiences and working this through together, even if it's just one person. I like to have a partner in idea sharing. So why don't we get started? So today is the goal was to network idea sharing of how-tos, right? We often create this elaborate plans and share ideas, and then it kind of goes nowhere. So this is hopefully will help us create the structure, at least of our thinking of how we're gonna present our goals to stakeholders in the way of a key driver diagram drafting or key driver diagram idea, right? And then talk about PDSA cycles. Why do we need them anyway? What is it and what do we eat it with? So, as you probably recall, the very famous the model for improvement. This is from the IHI, the Institute for Healthcare Improvement process model, very widely used in a number of settings, and what we try to do with the QI in healthcare is incorporate or kind of follow this model alone. It could be a little bit complicated, so I'll go through some of the ins and outs of how-tos. Because we often say, okay, this is an iterative process. Well, when I started, not that long ago, working with this model, what I'm hearing from folks, what does iterative means anyway? So, so this will help us hopefully understand those terminologies and why do we do first testing or piloting of stuff versus actually going full forward and implementing. So the model for improvement is guides us through this three major questions, right? What are we trying to accomplish? How will we know that the change is an improvement? And what change can we make that will result in improvement? And how we then evaluate our changes, possibility for changes, or rather preliminary changes, is through that plan, do, study, act cycle. So key driver diagram. Let me first, I think, back up a little bit as to why do we want it to have? Why is it? Why we don't even talk about this? Well, the key driver diagram helps us visualize, right? When we having conversations with our stakeholders, it helps us the whole group to get on, like what I say, on the same page, helps us visualize and how do we organize our improvement actions, right? So theory of improvement. So three main elements of a key driver diagram is an aim statement, which you probably are aware of, usually consists of some kind of overarching goal, and then a SMART aim. SMART aim stands for something that is specific, measurable, ART, somebody will remind me what that stands for. Timely is a T, and then A and R stands for
Actionable and realistic.
here you go. Good job. All right, and then the drivers, right? Remember drivers, those are factors that we need to influence the goal. And usually represented by a noun. Driver is a what and not a how, right? So the drivers, one we call a key driver diagram, the drivers that's what it's all about, is the what. And then interventions are the activities that may influence the drivers. And usually do answer the how, right? Okay, so this is the key driver diagram, the famous key driver diagram. So the idea is once you fill up all this squares and rectangles, you have a plan that could be communicated with a stakeholder, right? So it could be something that is very general, is like where we're trying to go, like having just a global aim. And it could be very specific, and we'll go through how can one make it specific to your particular project or your specific intervention you're working through. So for the sake of this presentation, we have addressed the SMART aim drafting in the previous sessions and have the recordings available on our website. So we'll provide that information. But for the key drivers, right, the circle in the middle is what we're going to talk today about. So how do we get there? How do we draft the key driver diagram? So one way, and this is not just the only way, there are other methods, but one way we often do it through the affinity diagram, where we brainstorm ideas, have those ideas usually on sticky notes, but we are in virtual environment, so we'll do it through the chat and practice together. So the second step is we put little those brainstorming ideas. You see those sticky notes on the right, they're kind of all over the place, right? So we then put a little category for those several ideas, and then put a little label that would help us get that driver into the place. Here's a little bit more on that. So for example, we brainstorm ideas and organize them in the groups. So this is categorizing. In this first column, for example, we have ideas for physicians not trained, staff not trained, no training for residents. Then we have another column with all the stickies that we now organizing on our step 2 and looking into that training would need to be scheduled, only scheduled 2 weeks out. There's like organizational things. And then third column, like what is it we're trying to prepare to schedule staff, right? Physicians all treated differently, and then handouts in for the doctors, handouts for staff. So we're trying to put that little into what category here as well. And how do we track activities? This is actually resonates you guys so much, and I'm going to share a really just quick. So we have a another committee that works on improvement on staff education and mental health in our hospital, and so we're learning that many are many are not even the folks that are providing education, our physicians, are not even having signing sheet to know how many people have attended their training. So this actually resonates very greatly with some of the projects that I'm involved with. So anyway, so then now it creates, as you see, 1, 2, 3, 4, 5 different categories. And so what we do with that that helps the thinking process is we label them, right? We kind of put them in the general categories and we say, okay, this looks like training, right? This looks like scheduling. This looks like consistency. This looks like participation, so we know who participates. And this looks like creating a timeline, right? So those orangey, yellowish labels are going to become our key drivers then, right? For this, whatever the problem this group was considering. So with that, and I'll go back. You can tell me to come back, and I'll come back to it. I know it's a little quick. I'm going through it. So if we are to practice together, our global aim, and this was just Anna's global aim. So this is for the sake of practicing, you guys. So don't have to disclose anything. We want to reduce a youth suicide. Now, I wanted to say something before we go into it, but so you have that background. This is an aim very, very high level, right? This is not specific, which we went with the specificity before and have information how to make it specific. But this is kind of an idea, right? Very global aim, and incomplete, because we don't know which area, which county, which hospital. We don't know with this one reduced by how much. We don't have a baseline. Youth, we need to identify the age, right? So to make it specific, who we're gonna address it too. And suicide, we don't know if it's suicide instances. So where do we get this information even? And is that somebody who were admitted to the hospital or somebody who had an ideation, for example? Those are important things to kind of walk through to make things more specific and to have a more specific goal. But this is not the focus of this session today. Today, we're focusing on key drivers. So if this is our reduce youth suicide aim, in our chat, I think we can utilize that. Let's come up with, and we're going to be back on this first diagram, step 1, brainstorm ideas. So let's take like 10 minutes to put in the chat what ideas do you have regarding reducing youth suicide. Any questions about that task? Let's do it. So what can help us reduce youth suicide? Build social connections. Excellent. Let's brainstorm a little bit more. Education, patient caregivers. All right, I'm liking this. All right. What else? Look for how we tracking the risk for suicide, restrict lethal means. Excellent. Involve family mental health conversations. Excellent. Education. All right, well, we got quite a bit. Let's see. So if we are to build social work, great. Let's see if I can stick it here. Those are awesome ideas. All right, let's look at this together. Oh my God, quite a list here, you guys. Good job. Okay. Yeah, that's fine. All right, so we have build social connections, engagement of leadership in reviewing processes. Okay. Then we have normalizing, talking about suicidal thoughts, education of patients, caregivers, families, education of youth, invest in resources for kids and their families, education for providers, involve family and mental health conversations, restrict lethal means, look at how we are tracking risk for suicide, and improve follow-up care. Okay, so those are some ideas. Any others? You can just unmute. So from these ideas, let's again step back here and look. So this is what we've done. This is our sticky notes, right? We kind of have them all over the place. So let's organize our thinking. If I can jump to the right slide. All right, so Loving those ideas. Great. So are you seeing, let's look together, are we seeing anything that is kind of similar? Anybody can say. Kind of similar.
Education.
Education. Yep. Education stands right away. Okay. So one driver we can identify as education. All right. Next driver. Next driver.
Probably family engagement or family.
Family engagement. Mhm. All right. Other drivers. Family engagement. Somebody said tracking, right?
Yeah, so
Tracking
maybe
risk
like
for society, like data.
or data.
Yep,
Mhm.
data. It's a good one. All right, education. Improve follow-up care. What can we align it with? Follow-up care.
Do you have something around communities, community engagement?
Yeah, like it's like those social connections and then that one at the end.
Well, let's pretend there's another key driver here. I do like restrict lethal means.
Yeah, that's
which
like
would
it's almost like a mitigation, or how can you, yeah,
a mitigation strategy, maybe.
yeah. like,
Mitigation strategy. Okay. I like that. That could
Yeah.
include both the follow-up and actually restricting lethal means into mitigation strategy. So let's put prevention strategy. How about that?
Yeah, prevention, mitigation, prevention, yeah.
Prevention, mitigation
Oops.
strategy. Okay. Did not spell it right. And it probably won't.
Are you saying mitigation or medication?
Mitigation, mitigate, prevent, move.
There, I put it in the chat. There you go.
Yep, got it. All right. So we have driver, key driver number. It doesn't, because they're all equally important. I prefer not to put numbers. So just a little asterisk here, family. So we know these are different drivers. Education, family engagement, data, and prevention mitigation strategy, prevention mitigation strategy. Okay. Thank you. This is awesome. Now, so these are now going to be our categories, right? That we split these ideas up into, and then we went further and put labels, right? Our labels are, instead of training, scheduling, consistency, participation, and timelines, for us, the key drivers are education, family engagement, data, and a prevention mitigation strategy. Okay. Any questions of how we've came up with this? All right, great. So now we are ready for look at how the team that is working on prevention in the hospital, the ideas they came up with and the key driver they came up with. And again, just a quick warning here. It depends on key stakeholders you work with and who you wanted to present this information, right? Just so this is very high level and at times could be confusing, but I wanted to share this example anyway, because team used the same strategy as the affinity driver diagram to come up with a key driver diagram. And as you see, this is very high level, but then has lots of things in it. So when what they looked at, the aim was reducing the youth suicide. They looked at the system, meaning the hospital systems, and they've come up with their own key drivers, which are somewhat similar to what we talked about today. So I wanted to share this example. So the key drivers were education, staffing support, access and availability, collaboration, and community initiatives. And you see, so depending on our aims, the drivers could be slightly different. However, do want to warn you not to, from what you're seeing is busy already. It's a busy slide. Wanted to warn you not to, sometimes it can be overwhelming. So it depends on who the stakeholders you talk with, that you might want to modify your key driver diagram and make it a little bit less of a drivers than you see right here, like what we've made here. 1, 2, 3, 4 are much more easier to digest than what you see on the screen. But I wanted to share this as an example for a larger hospital system, how this could look like. Now, looking at this, you're probably wondering, okay, what do we want to focus on, right? There's a lot of components here. And so as you see, almost every driver has anywhere from 4 to 6 to 9 and 10 interventions. That's a lot. Right. So to make it a little bit easier and digestible, the next steps you wanted to do with a group is to brainstorm ideas of interventions. And interventions are the changes that we think we can make, and we think it will influence our key driver and our final outcome of improvement or preventing suicide. Okay, so in our example, and I wanted to kind of share as to where this is stemming from, and then we'll go into the more details. So interventions. So interventions are change ideas, change strategies. You can probably hear many times people say different things and identify differently, but intervention is what we think we can do, right? It's to do is how. Answer the question how can we improve to affect the driver, and that it would affect the driver and then affect the aim. So as you see, probably very difficult to see, but I will, let me try to make it a little bit bigger. Some of them, like even though they're in red color, some of them are like more bolded than others. And so this is on purpose. So the group then, once they identify the key driver, like through the affinity diagram, like we did today, they sit down and they said, okay, here's things we think will help. But then some of them, the ones that are in dark, we think might be easier, might be more, not easier, but more possible to achieve. So what we then used, and this is something you could use with your groups, is we use this diagram that kind of says, okay, what are some things we can put that are high impact and easy to implement? And what are things we can consider that are difficult to implement, but they can bring some high impact, some high impact interventions with better results. So all these here listed, you guys, were from this list of interventions, because it's a lot. And so we've looked at several of them, as you see, we've discussed. There are some red notes here. And we said now this was about 8 to 9 people that brainstormed ideas and said, okay, we think the most important one, even though we identified several, would be obtain and provide safes and lock boxes to the community that we serve. So no other than, I'm thinking no other science to this except having this diagram and kind of help guide us and narrow down our hypothesis or our idea for testing. And that leads back to the key driver diagram that we talked about, right? There's a lot here. So how do we narrow down? We cannot be doing all at the same time. There's over 30 different interventions. So how do we narrow down? So this helps us narrow the problem down. All right, any questions as to from key driver diagram to what actions we're going to take next? All right.
I have I have
Yeah.
a question.
Yes.
Okay, so going back to the slide before this,
Mhm.
yes. So for each of the gray boxes, you take that and then you go to the slide number 14, and you put it in like the different quadrants there. Is that how you did that?
Almost. So
Okay.
so once we identify the key drivers, right?
Mhm.
Those with a finger diagram, we set several, we found actually another affinity diagram where we put, okay, what actions of how we're going to do
Sure.
this. And from this list,
Yeah.
I presented them empty, like there was nothing in the box
Right.
here. And I said, okay, what could be difficult to implement but has
Okay.
high impact? And they said, okay, we know it's going to be difficult to implement because of the A, Y, and C. But in like Jessica, like some of the things that hospitals struggle is to
Right.
even have a social worker present in ED. Like that was, we knew this is going to take money and resources that we may or may not have, and much more investigation, but we knew this is going to be in high impact. So that's how we came up with then isolating. And this see, the reason I highlighted the orange is
Mhm.
because this is the one you want to start with, because it's easy to implement. At least the group feels that they can do it, right? It's easy to implement, and we know it's a high impact because the statistics or research. And we had a group of different social workers, providers, QI specialists, behavioral care specialists, psychiatrists, psychologists, who sit down and said, okay, we have the data to say, and we do, we now know that even having the barrier for a kid who has suicidal ideation, from that suicidal ideation to having a barrier to the guns or medications, whatever that group wants to focus is like the thing you want to focus on, because the statistics say to us, if we don't have those barriers, the outcomes could be awful, because it is from the time the ideation took place to the time to action, either cutting or getting a gun, is actually 10 minutes. This is the brutal statistics that we know. And so we decided that this would be the action we want to. It's somewhat easier to implement because we felt we had a support, and it's not of a much of expense, but the impact is huge. So that orange category is what helps you kind of narrow down from, I think that was your original question, from all these here, right? The orange category here that is easy and high impact, that helped group to focus, right? What do we want to focus on out of those 30 interventions? We think this could be possible. And it is very in a QI improvement process. And I don't know if Jen stepped off or here. It's very important for groups to feel empowered that we can achieve, even if it's one important goal, but it's possible to achieve. So we can then learn from the success and then move on to something greater, bigger, and so forth. So that's one way of having fill up this diagram, helps them narrowing it down. All right, I probably forgot something, and I know my esteemed colleagues can probably help me here. For narrowing it down, Jen, any other suggestions? I know this is what we're using. Have you used something else from when you have this huge amount of interventions? How do you narrow it down for a team? Something to focus on.
No, I think this is a pretty useful tool. I've done this in the past with teams, and if we still have like a lot of high impact, easy to implement. The next thing we look at is just general timelines, like how long will it actually take to implement? Is it a week? Is it a month? You know, who else do we need at the table? So we've kind of looked at like time-based considerations too, to maybe help narrow it down a little bit more.
Thank you. Yeah. So, and we do know, you know, from the previous experiences that the groups usually tend to stay more engaged when they feel there's something they can achieve within like reasonable time. So timing is great, but then it also empowers to do more greater together as well once we have this one win that we could do right now. And so this is what our group came up with. Want to go back to circle back to Jessica. You said you have a question. Did we answer the question?
Yes, you did. Thank you.
All right. Okay. So our remember those QI project charters we talked about? So from idea to implementation, that also helps. I use this QI project form also help kind of solidify what do we want to do, right? We now have this, you know, number of sentences, a number of ideas. Like how do we then use QI project charter outline to help us focus, right? Remember how I said our goal was really like all over the place, big goal? This helps us focus. For example, this time group decided this is going to be a medication and sharps lockbox distribution project to prevent harm for self and others. We identify our group. So you have those little reminders. You might want to come back throughout the entire project because now it's a project, right? This is how we help ourselves organize our work. We now decided that our population is going to be 17 years old and less. And this outline on the left, the project title, the department, the population, the brief project description, the measures prepared by, and a date kind of help organize the group's thoughts. And so here's our project aim, and this is our proposed measure. Measure is at this point is nothing but a hypothesis. We think will happen. Like we will have 100% of patients who receive the lockbox will not be readmitted to the ED within 30 days. So this is what we were trying to achieve here now. So it's gives us even more tools to make it more specific, which often groups I know struggle. So I did use a QI project charter just for the purpose of organizing our work. And then going in a little bit more deeper and to say, okay, what is our scope? So it's like a little summary we put together. How are we going to achieve this, and any requirements of specific that we can exclude from the scope. And we decided that we're not going to be providing lockboxes for the families that already have them, right? So we're going to ask them if do you have a lockbox. That would be a disqualifier then from this initiative. All right, and then the form goes further down and explains, you know, who are our stakeholders. In our case, it was ED staff and our mental health unit staff, and we looked at the risks. Okay, so we know we're going to provide the lockboxes, but what is the risk? And we identified that there still could be harm coming to the patient, even though we've provided lockbox. So education must be another component of it. So it kind of helps us delineate what else should be going with our first testing. Again, this is all in that one form that we've provided earlier to the groups, and have that as our resource on our website. Okay, so that's where the Plan, Do, Study, Act comes into place. The purpose is to reduce the risk associated with a change while increasing the probability change will be effective. So it helps build common interest understanding, evaluate costs and side effects, explore theories and predictions. Just like we talked about, our prediction was we were going to reduce patients' harm, and test under various conditions. learn, adapt, and decide. Adapt, adopt, and for the next test, it needs to be happening or not happening. So that's in a nutshell about plan, do, study, act, cycle. Another way of looking at it, just the same, so hopefully it'll sinking. So planning is an adoption and implementation plan, is where we draw the SMART aims, select the change strategies, just like what we did together today. Do put the plan into the action. So it's a rapid testing. So we're testing our ideas, and then study. We're looking into, are we going to keep to what we decided to change, or are we going to change, or are we going to, get rid of it? It doesn't work for us. And that's then leads into the act. So work PDSA results examples. Working with stakeholders, again, starting with higher levels. This is the form, another form we used, which was also very helpful. And I'm going to talk about this, and then we'll practice some of the PDSA ideas for our project that we started talking about today. So our project was, we were going to give the log boxes to prevent harm, and we were our team. You can see the name of our team. Now, we did identify to begin our project, we didn't have the money, right? We didn't have the funds to do it, but we learned that kids who had certain insurance, their caseworkers were willing to provide those lock boxes for free. So we thought, well, what an opportunity to just trying it out, how this works, and if our hypothesis will produce any fruits, if they're going to be helpful or not helpful to our kiddos in the community. So following this, again, another form, but it kind of helps you walk through the problem with the team. So PDSA cycle form. We also looked at, we did start our first PDSA cycle, and our goal was a reduced 30-day readmission in our ED, and this is from the initial ED encounter, first time the family presented to the ED, for all the patients who received lock boxes. Our SMART aim, the reason we call it SMART, because it has the percentage. We have the particular goal: 100% of our patients who receive the lockbox will not be readmitted to the ED. And then we identified, following this form, who would be responsible. You see some names here. How are we going to keep our record? In the beginning, we had like paper record where we put the patient's labels and then follow them. So very simplistic one small way of testing the change. And then we are still working on this. So our do and study and act are still in progress. But then, as you see here, we did discuss already problems, and we did have some opportunities to improve this process in our EDs. And then we also encourage other units to try it out and have a little follow-up with patients, and saw that there are some positive outcomes. Our patients did not, 3 to 4 patients that we found did not come back to the hospital who received the lockbox. So at this point, we are looking at whether the action, right? The act we talked about, we're going to adopt, adapt, abandon this change. And what is looking very optimistic is we're probably going to recommend the adoption of the change, and we're going to probably spread it to others. And so this brings me to that narrowing it down makes it easier and more digestible for the team. So at this point, and I wanted to share this, the key driver diagram could be very simplistic, right? It could be, what are the steps are we working on right now, and how do we get there for the team? So remember the goal that we identified that has actually changed. But it is that we will not have patients representing to the ED. And we did actually met the goal. I'm still working on it a little bit longer, but for this SMART aim that has the percentage, we decided that there are certain steps, or rather certain processes, that need to be our key drivers for this small change. Is the research and create the process, testing of the process, spread and share, and then we'll be working on funds to sustain, like sustainability, right? So in this kind of, when we talk to our stakeholders, we can say, okay, so we've researched the process. It is ongoing, so we're working on that. We can show that. And then we are right now in the testing phases, and hopefully by the end of the cycle, we will be sharing and spreading. We are identifying now how to and where to find the funds for sustainability. So this doesn't, the key driver diagram does not have to be complex either. So it depends on how you and what problems you're trying to achieve. And hopefully I didn't confuse you further, but I hope this demonstrated how from the bigger issue, we can narrow it down to something digestible. How do we eat an elephant where there's so many little things happening at the same time? Is to one bite at a time. And this is one bite that we could bite. Okay. So, and then because this team is particularly achieving progress, they feel like they're achieving progress, and our readmission for this patient population reduced, we feel like we can move on further and looking into other opportunities within the system. So with that, let's practice. So we remember our first exercise, it was reduce youth suicide, and our key drivers were, let me remind you, they were education, family engagement, data, and prevention mitigation strategies. Again, very large and kind of like many things can go here. So it's a more general goal, and these are very general drivers, right? So let's brainstorm as to like one action that we can make or test for this goal. One hypothesis, what do we want to test? What could we test? What is possible? 3 of us working on this project. What can we test? Let's think of one action we can take. Well, maybe we'll start by deciding which driver do we want it to address. Is it education, family engagement, data, or prevention mitigation strategy? Anybody can put it in the, whoever puts it in the chat first gets a prize.
Well, maybe data, or yeah, Jen said education, but I was like, maybe data. I mean, how do
Okay, I like it.
What's our data tell us? You know, maybe that'll tell us where to start. I don't know.
Okay, I like it.
Or
So
we know education.
all right. Good either way. All right. Well, let's do both. I mean, we don't have to. So let's do for data. What would be our first thing we want to know? First hypothesis we wanted to test. So we can then PDSA cycle it.
I'd probably want to find out how we're currently capturing that information about youth suicide.
Do we capture this? This has been, yeah, it's interesting. It seems like a simple question. Not a simple answer.
Yeah.
Not a simple answer.
Have had a suicide risk screening, and how many are, I don't like, how do you capture it?
Yeah. Good one. So maybe finding, let's see.
Like, can we like look in Epic, like the medical record, to see
Epic,
the number of patients that have screened high or moderate on suicide risk screening? I don't know. That would give us a sense of how many patients we've had with
Or
either
risk screening.
high or moderate risk in the emergency department,
Mhm.
then we could target our education.
High or moderate. So this is a method of gathering the data, high or moderate. Okay. Okay. And then education, somebody said one hypothesis we can make is what was it? What can we test? One action.
See what current education we have.
Very good. So what do we have? Like baseline, education
Yeah.
baseline.
Assess current, yeah.
Baseline. Okay. And education of whom? I can't remember. We put several things, but let's be more specific here. If we are hypothesizing, is that education of providers, of families, of what?
Start
We
with
don't have to be right. Just put in anything.
start with
Here.
providers.
Education of providers. Okay. Okay. All right. And so from this, guys, I am going to, let's see, what do I have next here? From this, we can then, let's discuss this. So let's take an example of how do we capture it? What are some steps that we can use to like navigate this capturing data? Who can we engage? What are some of our ideas? We're doing this kind of this part of it. Let me see, where is it? We're doing, and I will come back. A background of it, right? We kind of organizing our thoughts and looking at who we are, how we're going to organize our work. So going through the QI project chapter charter steps, right? And then what is our scope, right? We can discuss that a little bit more in details here, and then testing, our first PDSI cycle is testing and looking where do we go for this capturing data. So Dina suggested EPIC, looking at EPIC for risk screening, high or moderate. It could be our first, right? Our first testing is to actually go into EPIC and ask data analysts or whoever you have on your team helping you with this, is is it possible to even pool this data, right? So this could be our first PDSA cycle. Yeah, thank you, Joey. This could be our first PDSA cycle. What else can we be doing at the same time with data? What other sources of data could be available to us? I would just maybe put it that way. Besides EPIC.
We could look at state level data or county level
Yes,
data.
thank you, Jessica. Yes. State level data. Yeah. Do you
Get
guys
my head out
have
of the hospital.
yeah. Do you guys have data available through like data agreements with the state, or like for the population who, you know, with a certain age has passed away, and what reasons why they passed away?
Not necessarily, but we do work closely with our child and death review team,
Okay.
child death review team, and look at the recommendations that they provide and work from there. So we don't have those agreements, but we also are within the same unit. So we
So we have
work
it
closely with
accessible.
them. Yeah.
Mhm. Mhm. Yes, yeah. So we could be looking at several data elements, right? We could be driving from the state level data and comparing, and we could be looking at the EPIC, the medical record, if we have the agreement, or the group that collaborates with us, like a hospital or school could be bringing that information to the team, depending on who your stakeholders are. And so that already, those are 2 PDSA cycles. We're just, so it's not a big like process. It's really like getting different, gathering data from different environments. So if we are switched to the education key driver, education of provider baseline, that is that initial, like the first step is what, like you're already doing, Jessica, in Nebraska, like having the stakeholders at the table, right? That's the first PDSA cycle. So, and then learning about their needs. That is the second cycle, right? What do you guys need? What is the needs assessment should look like? Where can we work together? So a little bit about PDSA cycle, and then I know we need to finish up. And if there's a particular project, Jessica, you want to work on, we can set up a session individually and just work through that project together. Just have those in and outs. But for if we're doing, and again, there's a different level of how you can implement the PDSA in your work, and it could be like an ongoing and improvement project, everything we do, right? So multiple PDSA cycles for testing to implement may look like this, right? The initial thought, the initial PDSA cycle with the data, right? This is where we can find the data. Well, now we can implement another stream of data is from on the state level, like wide scale, can't talk, scale testing of change. And then once we deliberate, what our one step we can take is what is our implementation of the change, what change needs to take place, whether it's providing log boxes to the community or education about where to find the resources. I mean, it could be a number of things. And again, to narrowing them down, use that other option. So we set a high impact, low impact screen. That's another way of how to narrow stuff down. So PDSA cycles are not difficult to think. Basically, it's testing the hypothesis, the idea of improvement over in the different environments. Is one way of thinking this through. And so testing, why do we want to test? So why PDSA cycles is trying and adapting ideas and knowledge on the smaller scales. It's like piloting, right? And the reason we want to do it is to learn what works and what doesn't, right? What can we tweak? And implementation on the bigger scale then is once we figure out what works and what doesn't, it is this then we can making the change, the actual change, and implement it into the day-to-day operation. So this is how we now have created a new stream of work, and now this is a permanent change, and this is how we now do our work all the time. So having the change is a part of our workflow. Now it becomes a part of the orientation process for our new employees. When they start is now it's part of the workflow. So this is not anything new anymore, and everybody's using this, or everybody knows this is our process. And that's so PDSA cycles help us learn and help us kind of get there. But that's the difference between testing and PDSA cycles, and then implementation is actually what's the word I'm trying to think of the word, kind of in grounding it into our everyday operation. That's the difference. All right, well, that's all. Thank you for your participation. It's been fun. We are going to save this recording, so if you forget anything and you're struggling, you can come back to it. Our next opportunity to meet and learn is going to be for all the PMHCAs in the webinar on August 27th at 2 p.m. We'll be talking about discharge from AD and safety planning. And with that, we can stop recording. And any questions, please ask.
In the